So
Okay.
the tendon sheath,
Yes.
it is basically a tube sock, which two flexor tendons run in. Okay, and then there's a sort of those are the two main structures inside it. But then there's the lining of the sheath, and there's some structures just next to the sheath as well called the obliques, oblique distal sesamoidean ligaments, and then there's also something within the sheath called the manica. All of those look very normal to me. The only thing I see in there is extra fluid, and then there's this little wad of extra tissue on the lateral side.
What is that? When you say lateral,
Yeah,
right there?
it's right here.
Yeah.
Exactly. Right there on the outside edge. And so because I don't see a structural abnormality in the sheath, I feel very comfortable saying let's knock the inflammation down with a steroid injection and HA, and then be conservative with her work while she's on that because it masks things. But keep her going, don't lose your muscle mass, don't, keep her leg. Actually, that's the other thing with the sheath is you need to make sure if it's normal to keep it moving through a range of motion. So I do want her to canter, I do want her to trot, all of those things so that her fetlock does normal motions. And then as the steroid and HA are wearing off, hopefully the sheath
And
stays.
how long does that take?
It takes about a month, which is where you would then, if everything looks really good at the end of that, you step back up into normal work.
Okay.
The sheath is a little bit like a balloon. Once it's blown up a little bit, it never quite shrinks down exactly to once what it was. So you may not, when the steroid wears off, have a perfectly tight leg. But what you want to make sure is that it's not progressively getting bigger and bigger and poofier on the side. Okay. So as it is right now, again, structurally she looks very normal in her sheath.
Okay.
But one of the things that we worry about in the sheath is that things start to, when there's enough inflammation in there, they can start to Velcro together, things that shouldn't Velcro together. And then that reduces their range of motion until one day where they take a step that goes beyond what it should, and it tears the Velcro. And if the Velcro tears in the center, that's great. But if it tears where it attaches on one end or the other, it can actually damage those flexor tendons or the lining of the sheath. And then it causes more inflammation, which then cycles back around, having more adhesions and so on. So that's why we want to knock it down and keep her in some light work, but not go all clear.
Should she be wrapped when she's in the stall?
I think maybe the first couple days right after the injection, but then after that I probably wouldn't.
And we'll put a little bandage in after we inject her. That'll have a little pressure on it.
Yeah.
And we just put a standing ankle
Okay.
down.
Okay. What about shoeing?
Yeah.
Rolling her toe a little bit to alleviate.
Having an excessively long toe does increase the stress on the flexor tendons, but actually changing that, what's happening on the sheath is a pretty hard thing to accomplish shoeing wise.
Okay. How would
Where
you
is she in her
assess
shoeing cycle right
She
now?
was just done. Maybe a week?
I would say she's a little longer on her left than she is her right, the way she's standing looking to me right now, toe-wise. And she's a little low behind, but not awful.
No, her pastern axis is, what's that, Nancy? Don't let her, because she may kick a foot. We don't want you on the other end of that.